All right. Welcome everyone to our second session for this viral lecture series. I'm really excited about all the participation and awesome questions. I am going to let Megan introduce herself, and then I will introduce our speaker today, Dr. Gensler, and then just quickly walk you through sort of the functions and how you guys can ask questions. So Megan, if you go ahead and introduce yourself to the group.
Oh, sure. Hi, I'm Megan Lockwood. I'll be one of the co-moderators today. I'm a first-year fellow at Mass General and a member on ACR's Fellows and Training Subcommittee.
Great. Thank you for joining us. So Megan and I will be sort of sorting through your guys' questions as they come in. Again, all of you guys are muted, all of the attendees, and there's some functions on the bottom of this Ring Central platform. So if you press on the chat button, you can write any general comments, and that means everyone can see them. If you're having technical issues or difficulties, click the raise your hand button, and that'll notify the host, who's Ngozi, that you need some attention, and she'll send you a private chat to try to figure out and problem solve with you. And then the Q&A button is to post any questions relevant to the lecture. These can only be seen by myself and Megan, and Dr. Gensler will be focusing on delivering her slides. So we will try to, like I said, go through these and ask anything during the session if it's really needed. Otherwise, we'll hold it till the end and do the Q&A period. So with that, let me introduce our speaker today. Dr. Leanne Gensler is an associate professor of medicine at UCSF and holds a joint appointment at the UCSF Health and the San Francisco VA. She's the Rheumatology Fellowship Program Director and the Director of the Spondyloarthritis Clinic and Research Program, where she performs epidemiologic 2015 and 2019 ACR treatment guidelines for axial spondyloarthritis. As an educator, she has led the resident elective in rheumatology for more than a decade. She has directed curriculum development in rheumatology at UCSF and received the Ira M. Goldstein Teaching Award in Rheumatology. She currently serves on the ACR SOTA Planning Committee, and she is, I've heard her speak before, and I'm really looking forward to her talk today. She always does a wonderful job, and thank you so much, Leanne, for joining us. And with that, I'll let you get started.
Thank you, Anisha, for that introduction. It's such an honor and a pleasure to be here today with all of you. And I want to take a moment to say how impressed I am on a daily basis with all of our trainees and colleagues' flexibility and resilience, both at the workplace and in the way we learn. So let's talk a little bit about cases and mimics in axial spondyloarthritis. Here we go. This is just my title slide, my disclosures. And we have three sort of items that I'm going to outline today. First is we're going to use a case-based approach. So we have 4 cases to highlight axial spondyloarthritis, both cases and mimics. The purpose of the cases are really to broaden your differential diagnosis and illustrate how historical laboratory and imaging data contribute to axial spondyloarthritis diagnosis. And then to discuss disease management in more complex cases, and I have an example or two to show you, and hopefully this will lead to lots of questions on the chat. So I'll start by saying when we think about disease, we should think about it in terms of not just diagnosis and the mimics that they create, but also how disease activity itself can sometimes actually be a mimic as opposed to the disease itself. And why this is so important today compared to years ago is really, if you think about, here we go. If you think about the fact that this is really a problem in 2020, in the last decade or so, but if you think about 2000 and the disease state of axial spondyloarthritis, it was really ankylosing spondylitis that was the disease, and nobody was going to confuse a bamboo spine and fused sacroiliac joints with much else. So the mimic of AS was quite a small problem in 2000. But in 2020, with the spectrum of axial spondyloarthritis and the multiple ways that we can use imaging to diagnose it and the heterogeneity of disease, it becomes a more difficult disease to both diagnose and to detect disease activity. So there are not many mimics of ankylosed SI joints and bamboo spine, and the heterogeneity is what probably increases to the risk of misdiagnosis. As you know, back pain is common, and so even inflammatory back pain is neither sensitive or specific. And we are learning that bone marrow edema on MRI, which we thought was very suggestive of sacroiliitis, may have a broader differential and may not be disease. In addition, our only biomarker of disease activity that we have serologically is the CRP as a measure, and that is not present in all patients, and when it's present is not specific. So this just highlights the example, and there have been several studies now showing healthy athletes that when exposed to mechanical loading, the SI joints can develop bone marrow edema. This is a classic place for non-pathologic bone marrow edema in the posterior segment of the iliac bone. This is not sacroiliitis, but it might be thought to be sacroiliitis, and radiologists might broaden that differential for you, making it more tricky to detect disease from mimic. So let's start with a case. This is a 31-year-old male who presented with low back pain that started 5 years before. He noted that the back pain was progressive in the last 3 months, worse in the morning and the evenings, and having about 30 minutes of morning stiffness. Running would make it worse. NSAIDs were helping. His review of systems was also significant for an 8-pound weight loss in the last 6 months, diarrhea, back and knee pain. He denied any rashes or eye inflammation. And his past medical history was significant for Crohn's disease with both ileal and colonic disease. He had received TNF inhibitors in the past, but lost response. And he had a past diagnosis of peripheral arthritis associated with his Crohn's disease. And in fact, prior to seeing me 2 weeks before, he had been prescribed a TNF inhibitor for the association with his active Crohn's disease and the back pain. He also had a diagnosis of pancreatitis from 6-MP. So this was his physical exam for me. Notables are his BMI is a little bit low and a lot of pain. Really no evidence of joint tenderness or swelling, no dactylitis or enthesitis. He had no psoriasis or nail dystrophy. And his exam for metrology was largely unremarkable. He had normal measurements throughout the spine, as we would typically do. And I think one of the pearls here is to remember that the physical exam may not reveal any musculoskeletal abnormalities in axial spondyloarthritis. And this is particularly true in people with early disease or people without a lot of damage. That metrology really is a reflection of either high disease activity or damage. So important to think about patient-reported outcomes. And here you can see that he has the BAS-DI is the disease activity index, and the BAS-Phi is the functional index. And those are not normal, though the scale that I would use for moderate is 4 and high being 6. And then you can see his patient global with a CRP that's quite elevated. And this gives us a composite disease activity of the CRP of 3.3, and that gives him high disease activity. So what do we know about him? We know he has active Crohn's disease. We know that he has inflammatory back pain. We know that he has raised inflammatory markers and that he has high disease activity and specifically about both Crohn's and high back pain. So we know he was started on a biologic 2 weeks earlier, and perhaps that's too early to tell that there's a response. And so the question is, do we need to do any additional workup to further evaluate this patient? I would give him a probability of axial spondyloarthritis of moderate based on the above features. So additional laboratory workup include a CBC with a little bit of anemia. His HLA-B27 is negative, but I should make the point to note that he is not of Caucasian ethnicity. His TB test for LTBI is negative, and then we talked about his inflammatory markers, and you can see a little bit of a low albumin there. This is his X-ray of his sacroiliac joints. We use an AP pelvis view, and these are largely normal sacroiliac joints. The read suggested normal hip joints, sacroiliac joints unremarkable, and of course, no acute RCS abnormality. let's talk about his MRI. So I did order an MRI, and I think in the setting of not having clear sacroiliac joints, and potentially even when they are more obvious, the MRI gives you information about disease activity and about structural change, and those are helpful for both prediction of response to therapy and also prognosis. And so just to remind you what these sequences are that we use for the sacroiliac joints. So this is an MRI of the sacrum or pelvis. And these views are coronal oblique views, so they give you the best cone down view of the sacroiliac joint. The T1 view is a fat sensitive view. So you can see a little bit of fat here in the corners. And this is best for structural change. So if you're looking for ankylosis, fat metaplasia, erosions, this is the best sequence to look for those on by standard imaging. And then when you're looking for inflammation or bone marrow edema, typically seen, you will use a STIR sequence, or you can use a T2 fat suppressed sequence, but typically a short tau inversion recovery sequence is what's used. And that's a fluid sensitive sequence. And so anything that's bright will be fluid. You can see a little bit of bright signal here in the sacrum. So the sacroiliac joints you can see over here, and I hope that my pointer is visible to you. And the fluid sensitive sequence on the right. Important to note that what is fat sensitive on T1 will be fat suppressed on STIR, and what is fluid sensitive on STIR will be fat suppressed on T1. So the first image of the sacroiliac joints, you can see actually relatively normal looking on the slice sacroiliac joints, and then bone marrow edema in the sacrum, not close to the sacroiliac joints. This is the next slice, and you can see further bone marrow edema of the sacrum here.
Leanne, just so you know, we can't see your pointer, so you're
gonna.
Oh,
you cannot.
We cannot see the pointer.
Oh no, that's unfortunate. Okay. So this is another sequence of the sacroiliac joints, and again, you can see the bright signal on the right side. That's the STIR sequence, again suggesting that there's bone marrow edema on multiple slices of this MRI. And then the axial. So we don't use the axial sequence very much to look for the sacroiliac joints, but it is done and can be helpful. And in this view, we now see on the right side in that STIR sequence a thin, what looks like a tract. And this tract is probably a fistula that's connecting the sacrum to the rectum. And this is actually a fistulizing lesion with osteomyelitis, unfortunately. So this bone marrow edema pattern, this is the report, is suspicious for osteomyelitis. And there's that small fistulous tract, and then a fluid collection in the rectum with abscesses. So of course, this is not sacroiliitis in the setting of Crohn's disease. This is actually osteomyelitis in the setting of Crohn's disease in an immunosuppressed patient now. And so the teaching point here is that infections can certainly mimic axial spondyloarthritis, as you just saw with this case of infections can mimic cases of axial spondyloarthritis, as with a case of osteomyelitis. And this is especially associated with active Crohn's disease and people that fistulize. Not all Crohn's patients do. And then thinking about other causes for infections that may mimic axial spondyloarthritis, so certainly the sacroiliac joint is a good septic joint, particularly in those that are immunosuppressed. Bacteremia, risk from IBDU, particularly with staph species. A postpartum state is a risk factor. And then think about those other atypical organisms like TB, other mycobacterium, and brucellosis. Many people will not have a fever in the setting of septic sacroiliitis, so it's still important to think about that in patients where the presentation may be a little bit more atypical. All right, let's go on to our second case. And we're going to lead with Crohn's disease in a 26-year-old male. This is a patient I recently saw who came to me for right hip pain. And his past medical history was significant for Crohn's that had been complicated by stricturing already and ileocecal resection. He had failed 2 TNF inhibitors, no history of ocular or skin inflammation related. His medications were ustekinumab, 60 milligrams every 4 weeks. And you should know that is a different dose than we would use in rheumatology patients with psoriasis or psoriatic arthritis, which is a Q12 dose and weight-based. His family history is non-contributory, and you can see his social history is fairly unremarkable. His physical exam, shown here, does not show either any significant inflammatory eye lesions, no skin lesions. He does have some cystic acne with scarring, but again, no peripheral musculoskeletal abnormalities, including joint tenderness or swelling, no enthesitis or dactylitis. And his metrology also is fairly unremarkable. So relatively normal cervical spine metrology, 60 to 80 is what's considered normal for cervical rotation. You can see his lumbar metrology, both bilateral flexion and the modified Schober are normal, and thoracic expansion is normal and his hip distance is actually a little bit limited. So this is his disease activity, and you can see he's got almost low Bath ankylosing spondylitis disease activity. His function is quite good, so his low functional impairment, the higher the functional impairment is, the worse it is. And his SID rate is 12, his CRP is 7.7, which is just above the upper limit of normal in our lab system, and his composite disease activity is 2.4, which gives him high disease activity. So this is his AP pelvis, and this is a patient who you heard had symptoms for a while. And what you can see on this AP pelvis, and I don't have a pointer to show you, but the sacroiliac joints are not normal in this view. In fact, you can see sclerosis on the iliac side of both sacroiliac joints, and irregularities suggestive of both erosions and radiographic sacroiliitis. His hip joints looked fine. So this is actually a patient with Crohn's disease who has ankylosing. Go back to imaging from 10 years ago, he had changes back then, and was being treated with a drug that actually doesn't work in axial spondyloarthritis. So this is his pelvis MRI. And so again, just remember the T1 is the structural change on the left and the fluid sensitive sequence on the right. And you can see that there is dark patches on the T1 sequence. That is a combination of sclerosis and the opposite of inflammation. And then on the STIR sequence, you can see a bright signal around, especially the right sacroiliac joint. And then the next sequence, you can see a little bit more, and you can also see some around the posterior sacral part of the left sacroiliac joint. So this is active bone marrow edema consistent with sacroiliitis from the patient's Crohn's and ankylosing spondylitis arthritis. This is his MRE that had been done 6 months earlier. And it's a bad image, but I am using it actually to make the point that we should be using incidental imaging to aid in our diagnosis. So this MRE was not done for the purpose of his arthritis. It was done because of his Crohn's disease. But what you can see, especially around the right sacroiliac joint, and again, I'm sorry that I don't have a pointer, is there is a bright signal that's active sacroiliitis that was already present. It wasn't called on the report. And in fact, that's highlighted by an abstract that was presented by Fardina Malik from NYU at ACR last year, where they retrospectively went back and looked at MREs of patients with IBD and showed that a significant portion of them had, in fact, inflammation on those MREs to suggest sacroiliitis. See in axial spondyloarthritis, this was 3 actually phase 3 studies that were done to assess ustekinumab and axial spondyloarthritis, and these are the data from the AS bio-naive group. And what you can see is that all of the dosing arms, so placebo in light gray, and then the 2 active arms in darker gray and black, were no different from each other across any of the domains of endpoints here, including the primary endpoint, which was the ASIS-40 shown on the far left. So ustekinumab does not have a role, unfortunately, in ankylosing spondylitis. And in this patient, it becomes tricky then what to treat him with, because TNF inhibitors really are the only class of drugs that will cross the spectrum of both Crohn's disease and ankylosing spondylitis. And if that leads to more questions for the discussion and for chat, I'd be happy to talk about some of these more complex cases after the presentation. So let's go on to our third case. This is a 30-year-old female with inflammatory back pain after delivering her first child. So she presented with pain on the left side in the hip and buttock and low back pain. And she had already been taking NSAIDs by the time she came to see me, stolen from her husband with good relief. And she really had classic inflammatory back pain, except that she had no clear improvement with exercise. Now, she had an interesting past medical history. She had JIA with affecting her knee with inflammatory knee arthritis. That had remitted, and she'd been in remission for years until her visit to me. She was known to be ANA negative. She had been treated with sulfasalazine in the past, but that had been discontinued. She also was HLA-B27 positive and had a history of recurrent anterior uveitis with her first episode just a couple of years ago. Her medications were the naproxen and a prenatal vitamin, and her family history was not contributory. Social history, she had no health-related behaviors or illicit drug use, and she was nursing her infant. This is her physical exam, and you can see she's got a little bit of pain there on her pain score. She had no synechiae in her eyes to suggest her uveitis had led to scarring, and her skin was free of psoriasis, nail dystrophy. Again, peripheral joints looked clear here, no swelling or tenderness of any joints, no enthesitis or dactylitis, and a normal gait. And then again, her physical exam is unremarkable. So you might keep wondering why I keep doing metrology on patients with normal measurements, but when you've done enough of them and one is abnormal, then it's really helpful. So when those metrology are limited, then there is some specificity in them. But her metrology here is quite unremarkable. And her patient-reported outcomes show a BAS-DI of 3. Again, I said 4 was moderate, 6 was high. Very low functional impairment, very good function or low functional impairment. Low patient global, and you can see inflammatory markers are normal, but this can be tricky, especially in patients that are female patients. They tend to have a lower serologic burden of inflammation. And you can see a composite disease activity there is actually quite low. So what should we do about this patient? She did get an x-ray, and the x-ray was relatively unremarkable. It says mild sclerosis of the bilateral sacroiliac joint. So a pearl to remember is that sclerosis is actually quite nonspecific. I wouldn't put too much weight in sclerosis around sacroiliac joints, particularly when it's mild. The right a little bit more than the left, it's not specific, maybe related to childbearing. That's another consideration that we'll talk about. She also has some axial joint space narrowing of her hip on the right side, and that may be suggestive of inflammatory arthritis. So certainly JIA patients can get hip disease. We see more hip disease in patients with juvenile onset spondyloarthritis. And so that might suggest that there is an inflammatory arthritis there. So what do we know about this patient? We know that she has JIA with possible hip involvement. We know that she's HLA-B27 positive and she has a history of anterior uveitis. We know she has inflammatory back pain that's gotten a lot better with NSAIDs. So do we need to do an MRI in this patient to further evaluate? Or can we stop and say, she has axial spondyloarthritis? And I'll let you think about that for a moment. I do think MRI helps. So I don't have histology like Anisha does to biopsy various organs to confirm the diagnosis of vasculitis. we don't biopsy sacroiliac joints. And so MRI is my equivalent to what sometimes would be akin to a biopsy, and is about as good as we have right now, unfortunately. So it does help confirm the diagnosis. It also gives you details about how much inflammatory burden there is, and that's helpful for prediction of response to therapy, and also structural damage. And so I do find it a helpful tool, especially when the CRP is normal and the X-ray is not entirely clear. I would give her probability, however, compared to the other patients, of a high probability of axial spondyloarthritis based on the features above. And so this is her MRI. And again, apologies for not having a pointer. You can see the T1 fat sensitive sequence on the left. So you can see the fat there. You can see her sacroiliac joints well. And then on the right side, you can see the stir sequence. So this is the fluid sensitive sequence. And I'm sure if you were sitting a long way away from the screen, you would see that bright signal on the left side in the sacrum. And the question is that left-sided sacroiliitis in this patient? And I would love to get a poll, if there was some way to poll you guys to see what you thought of this, because I looked at this, and when I first looked at this, I'm like, wow, she has unilateral sacroiliitis, except that the bone marrow edema. And so you can't see my pointer, but if you believe me when I say that the sacroiliac joint is to the left, to the lateral to the sacroiliac joint, then what is that line that goes through the sacrum? And I'll give you a couple more slices. That is a fracture. So this is actually a insufficiency fracture in a female patient that's postpartum. It is not sacroiliitis. In fact, her sacroiliac joint is beautiful on that side with preserved cartilage. All right, so sacral insufficiency fractures. She is not the only one I've diagnosed. You should think about this in your postpartum patients who you are evaluating for axial spondyloarthritis. There's a relative bone loss in pregnancy and in the postpartum state. And there's additional risk factors in these patients, particularly if they gained a lot of weight during pregnancy, if they have a high birth weight infant, or if forceps were used during delivery. So that would be traumatic. MRI is the gold standard for diagnosis here, and you can consider bone densitometry to evaluate for low bone mass in these patients. All right. Don't forget about this another mimic that's seen particularly in the pregnant or postpartum state or in multiparous women, so osteitis condensans ilii, and that is really a mechanical loading condition. What you see is this perfectly sclerotic triangular lesions on the in the iliac bones on the iliac side of the sacroiliac joints. There's no erosions there, and if you take a look, you can see the white, and then I'm going to animate it for you. So perfectly triangular. These patients can have bone marrow edema, especially early, and besides multiparous pregnancies, obesity is also associated, and the management is conservative. All right. Going on to our last case, and then we can open it up for lots of discussion. So this was a 19-year-old patient, male patient, that came to see me. He had already been diagnosed with axial spondyloarthritis, and he had come to the Bay Area to go to college. He complained of low back pain and low back, buttock, and rib pain that radiated to the back for the last 8 months. These episodes were occurring every 1 to 2 days every week. He had a lot of nocturnal back pain, waking him up in the middle of the night. No morning stiffness, interestingly, and NSAIDs really were helpful, so improved his symptoms 80%. His review of symptoms were negative for any constitutional symptoms. He had no GI symptoms, no rashes, no uveitis. That had been worked up, and I'll show you that workup. It was normocytic. He had actually been seen by a hematologist for this and was diagnosed with anemia of chronic disease or inflammation. His medications include naproxen, and his family history was significant for a grandparent with rheumatoid arthritis. He had no illicit drug use or health-related behaviors, and he was a college student. So his exam, when I first saw him, he was doing quite well, actually. On his naproxen, you can see his vital signs are normal. Musculoskeletal exam, also no peripheral joint tenderness or swelling, no enthesitis or dactylitis, no rashes or nail dystrophy. And then his metrology, again, is relatively unremarkable. Even the modified Schober's, and I know some textbooks will comment on a change from 10 to 13.5 or 3.5 as being limited. That is not true based on normal NHANES-based data, where actually the modified Schober cutoff is lower, closer to 2. All right. So let's look at his patient-reported outcomes, and you can see he has a low disease activity index, so that BASDI of 2 is considered low. He has good function. He has a low patient global, and he has a SED rate of 62 and a C-reactive protein of 14.6. So here we have a little bit of discordance in his current symptoms and his current inflammatory markers. And based on the composite, that gives him still a low disease activity because his PROs were so good. And so the question is, what do you do when you have discordance in your patient-reported outcomes and your inflammation markers? And this is an important, it goes in both directions. So certainly people can underreport. I have many patients that tell me they have no disease activity symptoms, yet they continue to have measurable inflammation. And if I did imaging, I might see actual inflammation of the sacroiliac joints or spine. And then we should remember that the inflammatory markers are not specific for our diseases, and so other things could certainly cause them. So let's get a little bit more information. This is his workup that had been done in the past 2 months for the anemia, and you can see his hemoglobin was 10. He had persistent inflammatory markers, rheumatoid factor of 9, which is normal. ANA was negative. His CCP was mildly elevated at 29. All of his ANA subserologies had been sent, not by me, which were negative. And then you can see workup for TB, HIV, hepatitis B and C, all negative. An SPEP and an immunofixation electrophoresis were normal. And urinalysis, thyroid, uric acid, all normal. HLA-B27 positive. And a radiograph of the hips, sacroiliac joints, and spine had been done at an outside facility and were normal. And in fact, an MRI of the pelvis had also been done, and that was normal. But the quality of that MRI was not great. All right, so what do we know about him? This is always tricky when someone comes to you with a diagnosis of one of our diseases. It's really hard to think about it, particularly in the setting of someone that's now treated and doing better. And we weren't there at the time retrospectively, so we put a lot of weight in our colleagues' evaluation of patients when they get a diagnosis of one of our diseases. So he has a diagnosis of axial spondyloarthritis. He has chronic axial pain with mixed inflammatory symptoms. So he had a good NSAID response and was doing better now. High inflammatory markers and anemia. HLA-B27 positive. Minimal pain today. A family history of rheumatoid arthritis and a CCP that's mildly elevated. And no, this is not a diagnosis of rheumatoid arthritis. And the imaging is essentially negative, except that that MRI was not great quality. So should we stop the $1 million workup? This patient has had so much of a workup, and he has enough features that we would worry about axial spondyloarthritis. And does it make sense to repeat any of the imaging studies just because they weren't great quality? I really like to use whatever imaging studies I have, including incidental imaging, as you saw from the MRE previously. Sometimes patients have had a CT scan for other reasons, and so using those results as well is helpful. So I would give this patient a probability of unclear spondyloarthritis based on this discordant data. At the time that I saw him, I actually said, you're doing well, you're on an NSAID only, so keep taking the NSAID, but let's continue to watch you. And that lasted about 6 weeks. 6 weeks later, he actually called me and he said he's having increasing back pain that's not responsive to NSAIDs. And a pelvis MRI was repeated at our institution. And this is the MRI. You can see the T1 on the left and the stir on the right. And there is not a lot of bone marrow edema around those sacroiliac joints in the stir sequence. But one thing that I am humbled about every day is my radiologist that I work with. And so this radiologist, who has saved me on numerous occasions, said that there was diffusely abnormal signal of the bone marrow in the MRI seen in the setting of significant anemia. So that could be the case, but infiltration could be at play too. So this could be an infiltrated bone marrow as opposed to just a bone marrow with anemia. In the absence of definitive diagnosis, bone marrow sampling should be considered. And there was no active sacroiliitis. So that's important as well. It's not just that we find other things on our imaging studies that account for the presentation as in a mimic, but also that this MRI, which was looking for sacroiliitis, was negative. This is the spine MRI that was done at the same time. And so you might see in the L5 lesion that there is a lytic area. And so these are actually bone infarcts that were seen throughout the spine and the sacrum. And that was acute lymphocytic leukemia, so ALL, and that was not sacroiliitis or axial spondyloarthritis. So hematologic malignancies can certainly mimic axial spondyloarthritis, as can bone tumors. And shown below is actually a case from Arthritis and Rheumatology of a patient with osteoblastoma who mimicked axial spondyloarthritis. These patients can have bone marrow edema, but this was actually a bone tumor. So musculoskeletal complaints, if we think about leukemia, and I've seen a few cases of leukemia present as mimics of axial spondyloarthritis. This is actually a very common presentation in kids with leukemia, with acute leukemia. It's not that common in adults, but it absolutely can happen, and we should be thinking about it in patients. This was a 19-year-old patient, so perhaps that may have been closer to pediatric disease than other adult patients. So think about leukemias and solid tumors in patients that are presenting with axial symptoms and even high inflammation as a mimic of axial spondyloarthritis. So this was a study done to look at alternate diagnoses using MRI. And what you can see here is that there are several things that you would be worried about missing. So certainly we don't want to miss tumor fracture infection, but if you look at the prevalence of those in this large group of patients that were studied, it's actually quite low. So these are low, these are high. We don't want to miss these, but the chances of finding them are still low. And then the more common things, which are much more prevalent, are, of course, things like degenerative disease. DISH is a common mimic, and then osteitis condensans ilii certainly is more common, especially in women. So in conclusion, axial spondyloarthritis can be difficult to diagnose, and certainly more so than the sort of only form of the subtype of the disease we had with ankylosing spondylitis. When we're looking at a more heterogeneous disease, we should expect that it will be more difficult, and we'll have to really put our thinking caps on and not just go to a single test to diagnose patients. This is especially true when people have earlier disease or when they don't have a lot of damage. And so you could see when people didn't have a lot of damage, they did not have a lot of change in their physical exam, their x-rays were not helpful, and we were really going to all of the other features plus the MRI. Symptoms and signs can be nonspecific, and imaging, if not perfectly, is not perfectly specific either. So it really needs the clinical context and discussion with your radiologist. I get on the phone on a weekly basis with our radiologist to go over my cases. And I have learned so much from those discussions. So the value of the MRI really confirms the diagnosis in the appropriate setting. It provides detail on disease activity, but also structural damage, and this is important for prediction of response to treatment, and it often reveals an alternate diagnosis. Disease activity can also be mimicked by other reasons for both pain and inflammation. I just want to acknowledge the amazing people I work with at UCSF, my colleagues and our trainees, and of course my two sites, which is the VA and UCSF Health. Thank you very much. I think we can open it up for discussion.
All right. That was a wonderful talk, and we got a bunch of great questions that have come in. So we tried to go through, me and Megan, and split them up kind of thematically, and we'll kind of do a few questions on history, physical exam, then imaging, and then we'll sort of wrap up with a lot of questions about treatment. So
Yeah.
Megan, I'll let you go ahead and start.
Yeah, so the first question we have is related to the examination, and what specific clinical maneuvers are practical to perform in day to day in the examinations of patients with spondyloarthritis?
So I'll break it up into two, both when you're thinking about the diagnosis and then when you're monitoring people over time. So actually, if you're evaluating patients in clinic and you're just maneuver, you can do the modified Schober, which is the forward flexion, but the lateral flexion is probably a little bit more sensitive. If you were just going to pick one test to do in the physical exam for axial spondyloarthritis as you evaluate someone for the diagnosis, it would be one of the measures of lumbar flexion, preferably lateral, but forward flexion is fine too. In terms of routine monitoring of patients, so it depends on, partly depends on the patient in terms of, I use it because we do less x-rays now. So I use it as a surrogate for damage and progression. And so I think that the cervical rotation is helpful and easy to do. It really just requires the patient turning their head. The thoracic expansion is also easy to do in that you can use the xiphy sternum, but you do need a tape measure that extends more than the paper tape measures. I like the occipital wall because it just requires the patient standing with their back and feet against the wall and really in a neutral position, getting their occiput to the wall, and then you can just measure with a tape measure. So I would say from head to toe, the cervical rotation. Thoracic is, if you just pick one, I would pick occiput to wall, especially if you don't have a long tape measure. And then forward flexion is probably the easiest one to do, with a mark at the dimples of Venus, and then 10 centimeters up with a forward flexion and remeasuring that distance. In addition to that, of course, I do a joint exam in every patient. About 20% of patients will have peripheral inflammatory disease. I do evaluate for hips on exam, though you can't evaluate for synovitis, obviously. And then I do evaluate for enthesitis. And I would say for enthesitis, the best places to really go are the heel. So really pressing to blanch the fingernail at the insertion of the Achilles tendon on the calcaneus, so really on the bony structure, or the plantar fascia aponeurosis on the calcaneus. And that's a yes, no, it's tender or it's not. How much weight you put into that tenderness being equal to enthesitis is debatable, but at least it's sensitive in terms of if someone's never had pain there and then they start to have pain there, it would make you wonder whether you should work it up.
Great, thank you. Anisha?
Oh, yeah, I will ask just some questions about the MRIs. So do you always check an MRI in all patients for example, if the x-ray already shows sacroiliitis or signs of damage, do you still go ahead and get that MRI? And then if you do you always use contrast? Kind of how do you, where does
good
it
question.
align?
Yeah.
Yeah.
So no, I don't get an MRI in every patient, because so I think if a patient has obvious sacroiliitis on an X-ray, then you don't necessarily need an MRI to confirm that diagnosis. When I tend to do it is if I'm not sure if the disease activity is coming from the disease. So the patient has ankylosing spondylitis, they have radiographic disease, but their CRP is completely normal and their symptoms are like a little bit atypical, then the MRI helps me to confirm disease activity. And it also gives me more information about structural change than the X-ray does. The X-ray, and so it's not just when the X-ray is positive though, it's actually how positive. So we have a grading system that we use for the X-rays, and if the X-rays are grade 3 or 4, which is partial ankylosis, joint space narrowing, pseudo widening, or complete ankylosis, then there's no question about the diagnosis. But actually, if it's grade 2, it could go either way. The same expert could read that X-ray differently on 2 different occasions. The ICCs are pretty low on that. Depending on how confident I am with the diagnosis, and then even in the setting of diagnosis, if I'm not sure on the symptoms being disease activity, then I will use the MRI to confirm disease activity. In terms of contrast, we do not use contrast. GAD is not needed for sacroiliac joints. Remember, this is not a synovitis, this is an osteitis. And so the STIR sequence is actually good enough to identify osteitis. If you were really looking for synovitis, so the one time I'll use GAD for sacroiliac joints is if I'm worried about a septic joint. Then you need GAD.
Thank you.
Yep.
Megan, you want to go ahead?
A question that came up is, how do you think about the difference between IBD-associated arthritis and ankylosing spondylitis or axial spondyloarthritis?
Yeah, that's so. So it depends. People are going to laugh on this in this chat, I'm sure, but it depends if you're a lumper or a splitter, right? So as a rheumatologist, when I think about them clinically, then I think about the manifestations. The patient has IBD, they have sacroiliitis, they have spondylitis. As a rheumatologist, I think about it in terms of arthritis, because so they have arthritis associated. In my mind, they have ankylosing spondylitis with IBD. But if you ask the gastroenterologist about the same patient, they would say the patient has IBD with arthritis. And so extraintestinal or extra-articular in terms of the manifestations. But I think it's actually, there's a deeper question there that we don't know. And is the pathophysiology. Drugs like ustekinumab, which work for Crohn's disease and don't work for AS, does that mean that they also wouldn't work for the arthritis associated with Crohn's disease compared to a patient that has primary AS? And I think we don't know yet whether we can rule out IL-23 as a pathway in patients with IBD that have arthritis, in particular axial arthritis, because that particular subgroup has not been studied. Sometimes I'll use features like HLA-B27 to help me. So HLA-B27 is typically in the white patient, will be higher in a patient with AS than in a patient with IBD, but those are all relative. So it's tricky, and it partly depends on who's asking the question.
Great, thank you. All right, I'll move on to a treatment question. Do you always use NSAIDs before a biologic? And how do you decide, do you have a certain way that you decide if they responded or not responded? So, and what's your threshold basically to advance to using a biologic?
Yeah, good question. So unless there's a contraindication, I use an NSAID first. And I have gotten so many patients into remission with an NSAID alone. I am always impressed with the efficacy of NSAIDs, particularly in young people that have never taken chronic meds before. To go from nothing to biologic is a very big leap. So I almost always start with an NSAID unless they have a contraindication. The easy contraindications, if they have IBD. If they're older, I become a little bit more hesitant. So above 65, I make sure that I am adding a PPE if we're really doing an NSAID. And if they have cardiovascular disease, that would be a contraindication for me to use a full dose of an NSAID, because really you need a full dose. In terms of how long we give patients, so we typically will give, it takes about 48 hours to see effect. and about 2 weeks to see full effect of an NSAID. And the recommendations are that you try 2 different NSAIDs over the course of at least a month before you escalate to a biologic. And that's what I will do unless there's a contraindication. I'll just briefly mention in terms of what type of NSAIDs to use. So the ACR guidelines actually don't recommend a specific NSAID. Remember, those guidelines are based on evidence. And so if it's an NSAID that's been studied, there's not a lot of difference across them that are available to us in the United States specifically. That said, I do think that there is benefit to using extended release formulations of NSAIDs, and that's purely eminence, not based on strong evidence to say that extended release medications work better than short-acting drugs like ibuprofen. But if you just think about a patient's worst symptoms, it's when in the middle of the night or when they wake up in the morning. And so having that NSAID wear out of your system and then wake up at 4 or 5 in the morning with symptoms, including pain and stiffness, is not ideal. So I tend to use long-acting NSAIDs. And then even within long-acting NSAIDs, if it's a patient that's really young and they're not used to taking drugs, then I'll sometimes use a once-a-day NSAID like meloxicam, because it's just easier to take. And from a compliance standpoint, they're not going to forget about the second pill of the drug. But it's very much a shared decision in terms of what I use and how we proceed. And there are times that I will go straight to a biologic. For example, a patient with active AS that has really active, recurrent, and difficult to manage uveitis. That patient, I might start with a biologic if I'm trying to target both diseases. Does that answer the question?
Yes.
Great, thank you. There have been a few questions about non-radiographic axial spondyloarthritis, and if that may be outside of the scope of this talk. If so, we can move on to another question. How do you?
Sorry, we do have a talk specifically on non-radiographic spondyloarthritis.
Okay,
go ahead
cool.
and ask if you want to, but we do have a talk on that later in this lecture series as well.
If that's the case, then let's save that for the next lecture series. We've had a few other questions about the role for JAK inhibition in axial spondyloarthritis. Do you have thoughts about that? Yeah,
and so I'll first start with that. This would be an off-label discussion because we have no JAK inhibitors that are approved for axial spondyloarthritis or even ankylosing spondylitis. So there is tofacitinib. So JAK1/3, the phase 2 study was positive, and that is actually in phase 3 right now for ankylosing spondylitis. And so that's probably the closest we have to getting an FDA approval for a drug. One thing to know about tofacitinib is that even when it's approved if it is approved in ankylosing spondylitis, which would be fantastic and great to have a pill available to our patients over only injectables, it actually is not approved in Crohn's disease. So in a patient, so I showed you that case of the patient with ustekinumab, and though tofacitinib is approved in ulcerative colitis, it did not pass the test in Crohn's disease, and that could be partly study design, but actually it makes it a little bit more tricky for a Crohn's AS patient to think about treating. There are 2 more that have been studied, both in Crohn's disease and in ankylosing spondylitis in phase 2 studies, but so the first one is upadacitinib. So upadacitinib is a JAK1 inhibitor and is approved for rheumatoid arthritis just late last year. Its phase 3 data in Crohn's disease is fantastic, and its phase 2 data in AS was presented at ACR last year and looks good. So there's hope that might be an option for patients that have multiple manifestations. And then finally, filgotinib is not available at all yet by the FDA, but has good phase 2 data across the spectrum. So I'm hopeful.
Thank you very much. All right, we just have a few minutes. So there were a lot of questions that were basically for TNF failure. So you've gotten past NSAIDs, you've used the TNF, maybe you've tried 1 or 2, but they're failing. So would you add on another agent? Would you consider adding a second biologic to the TNF, or would you switch mechanisms, and what would sort of drive your decision with that?
Yeah, so it's important for us to make sure that they're failing for the right reasons. So again, this is the question of whether the disease activity is being mimicked by something else. So if someone truly fails if they are primary failure for a TNF inhibitor as opposed to they secondarily lose response, then the chances of them responding to another TNF inhibitor in the same class is low. The reported data from registries is around 10 to 11%. And so if they truly are a primary non-responder and you think they have ongoing disease activity, switching class may make more sense. In terms of truly failing two TNF inhibitors and you have done an MRI and you've proven that they have ongoing inflammation or their CRP is elevated then again, I would switch classes. I have almost never added, and again, we're going to talk off-label here because there is no indication for combination of biologics across the spectrum of this disease, but I would not generally add two biologics to each other. The one time where I have done that off-label will actually use secukinumab for their Crohn's disease, which is well controlled, and they really are a TNF failure for IBD, then I will sometimes cautiously add a TNF inhibitor, and this is totally off-label as I speak in front of 1,000 people. But we're talking about a handful of cases, and it's been described in the literature a little bit in some case series. But otherwise, I don't combine biologics for axial disease only.
Awesome. Thank you so much. Megan, do you have any last question that you'd like to ask?
Sure. We had, I think for a last question, there have been several questions about the probability classification you used in the different cases, and if there is a brief framework for how you developed the probability for each patient.
Yeah, there is. And I didn't show that. I mean, it's been studied a little bit where if you take the prevalence of AS in a chronic back pain population is 5%. So if you take that, start that as the base, and then you look at the sensitivity and specificity of the different features of spondyloarthritis, you can actually create a probability based on the likelihood ratios. So the likelihood ratios times each other will give you a likelihood product, and that can be converted to a probability. There's actually math behind it. And so if you think about the different features of spondyloarthritis, the ones that have the highest likelihood ratio are going to be HLA-B27, a positive MRI, and then anterior uveitis. Anterior uveitis has quite good specificity in association, especially with B27. So if I have a patient that has B27 positivity, anterior uveitis, without even asking them if they have back pain, the chances of them having spondyloarthritis is more than 75%. That's without even back pain. So it just depends on what the individual features are. But yes, you can actually use math to figure out what the probability of the disease is. And that's how I came up with those gestalts on moderate probability, low probability, unclear probability.
Thank you very much. Just in respect of everyone's time, I'll sort of wrap up. There was over 70 questions, and I love that people were answering each other's questions on this Q&A format. It's wonderful to collect everyone's knowledge together and teach each other. So Dr. Gensler, thank you so much. This was really a great talk. And for everyone that's attending, this lecture will be recorded and posted tomorrow on the ACR website, so you'll be able to access that to review any of the information. And I think tune in on Friday. Dr. Petrie will be discussing lupus, same time, same place. And I think that's about it. I appreciate everyone's participation, and thank you guys. Thank you, Megan, for moderating with me, and Dr. Gensler, of course, for this wonderful talk.
Thank you.
Thank you.
Anisha?
Yes.
I'm happy to, I feel like there's a lot of unanswered questions here. Is there a way for us to?
We will send you this little script of all the questions. I did that as well. There was like 100, and so there's definitely some unanswered. Don't feel obliged to send emails to everyone in the universe, but but if there's any sort of themes, then yeah, you'll have
Sure.
a look.
Happy to.
Okay,
Sounds
great.
good.
Thank you all.
Bye.
Bye.